So I've been practicing psychiatry since 1987, so about 35 years. And in that time, I've come to know how difficult it can be to treat depression and just how horrible an experience severe depression is. Here you'll see the initial CGI. And what that is a person's self-rating of their level of depression. Okay? So one day I was at a research meeting, this was in about 2014, and I saw this slide which came out of a NeuroStar study. And it shows the response rate for people with treatment-resistant depression who are treated with transcranial magnetic stimulation. I was impressed with the response rate, but there was something in this slide that I had never seen before. After completing TMS, people continue to improve. So look at the 12-month numbers compared to the end of acute numbers. You can see it goes from about 62% to about 69% after the acute treatment. This is unheard of in depression treatment, for depression to continue to get better after you stop treating it for severe depression. I found that really, really interesting and really exciting. With medication treatment of depression, one can expect about a 50% relapse per year. And even more if you've had more than one depressive episode. This slide, to me, suggested that TMS does not just treat the symptoms, it also appears to change the course of the illness. We think that it does this by improving neuroplasticity, which means the ability of neurons in the brain to grow, to adapt and grow, or the brain's ability to change and adapt. After I saw this slide, I knew I needed to be able to do this for my patients, so I purchased my first TMS machine in 2015. That was 7 years after it first gained FDA approval for treatment of treatment-resistant depression. In my office, Manlove Psychiatric Group now has 2 TMS machines and is the only TMS clinic in western South Dakota, though there are about 400 TMS clinics nationwide. We also have a clinic in Minneapolis, and we have a few TMS machines there focusing on treatment-resistant depression. I want to talk a little bit about the biology of depression. Now this is what I think of as being a very cool slide. If you ever wondered if people with depression have an organic illness, this proves it. It says organic an illness as a broken arm. We could show you an x-ray of a broken arm. This shows you a brain that is impaired. So a common finding in depressed patients is prefrontal or global hypoactivity. This slide shows 2 PET scans demonstrating this point. The left image is an axial image of a healthy adult control. So it's cut through the head like this, right through there. The right image is a depressed person. Black represents no metabolic activity, blue moderate, and yellow and orange more activity. Note the yellow color on the top of the left image. That's the prefrontal cortex. So the top of the image is the front of the head. And you can see that it's yellow. That's the prefrontal cortex. It's right under my hand here. And that's an important part of the brain for you to get your head around, because we're going to be talking about that a few other times through the course of this time. The image on the right is that of a depressed person. It's mostly blue, showing little more than moderate metabolic activity, particularly in the prefrontal cortex. So I want to just show this. This is a pretty busy slide, but this is areas of the brain implicated in major depressive disorder. I want to just talk about it a little bit. So the syndrome of major depression includes brain systems involved in the regulation of mood, emotional expression, reward processing, attention, motivation, stress responses, and social cognition. And each of these parts of the brain affect one of those areas. This function of the brain regions noted in this slide, and dysfunctional connectivity between parts of the prefrontal cortex, the limbic, which is the middle of the brain, and other cortical structures can account for the variety of emotional, cognitive, autonomic, and neuroendocrine responses associated with depression. I want you to take particularly note of on the right side of this image. That's the front of the brain, this image. And this is an image of half a brain. It's cut, well, it's actually 3/4 of a brain. You can see it's cut out in the front and cut from the side. Can you tell that? The yellow part on the front is the prefrontal cortex. And notice that is the part of the brain that is closest to the surface of all these parts. We're going to come back to that in a little bit because that's the part that we can easily access with transcranial magnetic stimulation. You can see just below that and in a little bit is the anterior cingulate cortex. Below that a little bit is the nucleus accumbens, which is sort of the pleasure center of the brain. And then a little farther down is the amygdala, which is sort of the part of the brain that deals with memory of emotional experiences. Each of those regions, each of those 4 regions that I just described are shown in this slide here. Again, now this time the brain is looking to the left side of the screen. And I want you to notice that they're connected to the brainstem through neuronal circuits. And that's what this purple line is. Those are neuronal circuits going to the brainstem. These neuronal circuits connecting these areas release what are called monoamine oxidase, or monoamine neurotransmitters. And you've heard of these words, things like norepinephrine, dopamine, and serotonin. And those things all come from nuclei in the brainstem. This is showing one nuclei, this purple ball on the bottom of the brain here. And from that comes these different neurotransmitters. When there's an appropriate amount of physiological amount of neurotransmitters being released within these neuronal pathways, communication among these brain regions is optimal and the brain circuits function normally. However, it's been hypothesized that if the neurotransmitters become reduced, depleted, or dysfunctional for some reason, depression may ensue. So there's a hypothetical link between the reduction of neurotransmitters in these regions and several of the symptoms of depression that constitute what we call major depressive disorder. So this is another brain, and it's looking to the left again. And that light blue area there, that is over the prefrontal cortex. And it's a little bit lateral, and so and that part of the brain is called actually the dorsolateral prefrontal cortex. That is the part of the brain that we can access with TMS, and it turns out that if we access that part of the brain with TMS, we can affect all those middle structures of the brain. And I'll show you this in a little bit. Before I do that, I want to go through a study with you it's really important for all of us to understand, or anybody who's interested in depression to understand. It's called the STAR-D study. That means sequence treatment alternatives to relieve depression. The National Institute of Mental Health funded this STAR-D study. It was conducted to determine the effectiveness of different treatments for people with major depressive disorder who have not responded to initial treatment with an antidepressant. This was the largest, longest study ever conducted to evaluate depression treatment. It went over 7 years. There were over 4,000 people enrolled in it. There were 41 clinical sites, and it ranged in age from 18 to 75. So it was a huge study. If you can just imagine putting that together. And so it really gave us a lot of interesting data. Participants came from all kinds of socioeconomic groups, and all the patients were diagnosed with major depressive disorder. The design of this study involved 4 treatment levels. These levels were pre-specified by an expert consensus, so they had expert psychiatrists come together and say, here's how we would normally sequence treating depression with different antidepressants. So it reflected the general approach to treatment of depression in 2007 when this was done, but it's very similar to the sequence that most people would follow today. First, people were diagnosed with major depressive disorder, and they were tried on citalopram. You can see that on the top there. If that didn't work, they went to the second level and were switched to bupropion, cognitive therapy, sertraline, and venlafaxine. And if that didn't work, they went on to level 2A. And if that didn't work, they went on to level 3 and then 4. So they basically, if one didn't work, let's see what an antidepressant that works in a different way will do. And each of these 4 levels are different ways that antidepressants work. So what did they find? So you may have seen patients in your clinic if you're a therapist, or you may know people who failed to respond to initial treatment with antidepressants, who then struggled to benefit from subsequent antidepressants. And the STAR-D study tells the same story. You can see that this slide shows at the start the remission rates broken by each level of treatment. So the vertical axis is percentage of responders. The horizontal axis is different levels of treatment. So the first one is 1 prior treatment failure, 2 prior treatment failures, and 3 prior treatment failures. And you can see that the first time, the first drug that people were treated with, they had a 27%, 27.5% pretty good response, which is horrible, right? I mean, just right out of the chute, it's not very good. So, if you come to see me and I'm going to prescribe a medicine, I'd say, well, we've got a 1 in 3 chance that we're going to help you. You might just say, oh, maybe I'll go somewhere else. The truth is, if you do subsequent trials, you get, you begin to pick up some more people. So whenever somebody comes in the first time to see me, I say, we're going to try this. If this doesn't work, there's some other things we can do. But you can see that if you failed one, your chance of responding to a second medication are about 20%. And then if you failed 2, then it's about 16%. Right? Yeah, and then if you fail 3, it's 6.9%. So if you're on your 4th antidepressant, your chances of responding based on this very, very profound study is like around 5%, roughly 1 in 20 chance of responding. I can't tell you how many people I've seen who failed more than 4 antidepressants in my treatment, in my treating life. So it's a bad story. There's a response, yes, but it's not very high. Antidepressant medications are thought to treat major depressive disorder by chemically boosting the synaptic actions. The synapse means the area between neurons of 1 or more of the 3 monoamine neurotransmitters, dopamine, serotonin, norepinephrine in the brain regions we just discussed. However, because antidepressant medications are ingested and metabolized systematically and then go all through your body, they don't just go to those neurotransmitters, they go all through your body. And so we have side effects from them. And this slide kind of shows, we would like it to just be in the brain, but the guy standing on the right is showing all of the potential side effects that you can have from antidepressants. So it's not a real clean treatment. You may be treating depression, but you're also affecting other parts of the body. So, again, antidepressant drugs can cause increased depression sometimes, disturbed sleep, common side effect of SSRIs, reduced interest in sex, common side effect of almost all antidepressants, emotional flatness, apathy, weight gain, a lot of problems that people don't want. So the STAR-D study looked at this also and showed the discontinuation rate due to side effects. While study discontinuation rates due to side effects was relatively low in the first treatment, only 8.6%, it went up rapidly, tripling at the second level, and by the time we got to the fourth level, not only were you only getting a 6.9% response rate, you're getting about a 40% chance. Almost half the people were stopping because they had side effects that they didn't like. So I'm just saying antidepressants are not a panacea. They definitely have a role in the world, and I use them all the time still, but there are reasons to be concerned about them. This is my final STAR-D study, and it shows that even after people in the study went through 4 steps of treatment, the total remission rate was only about 67%. So people who tried all 4 levels, if you added all the response rates together, it was about 67%. So that means, of course, that 33% of the people did not have a good response based on declining response. They went from level to level, and by the time they got to the 4th level, they really weren't likely to respond to an antidepressant. It was pretty clear. And probably the story here is that the antidepressants all pretty much work the same. They're a little different, but they probably all have functionally about the same effect. And I think that's maybe sort of one of the sub-stories in the STAR-D study. So TMS provides good news to the 33% who do not respond to antidepressant medications. So one of the things that comes up is, well, must be ECT, right? I mean, it's the same thing as ECT. Well, no, TMS is not ECT. It's very different. It doesn't involve sedation or anesthesia. It doesn't have negative effects on memory or thinking, which ECT does. And it's easily performed in an office setting. In fact, people have very few side effects from it. It's one of the safest treatments in medicine actually right now. It's pretty much does the same thing. Yet the only other thing that this includes is that you can use other therapies with it if you want to for a variety of reasons. It's not a problem to use medications with it because there's no interaction with medications. There's no drug-drug interactions. So people who have complex medical problems or are on lots of medicines, you don't need to worry about a drug interaction with those medicines. So, how does it work? What's going on here with this transcranial magnetic stimulation? So I want to just introduce you to this slide a little bit before I talk about it. You see that neuron in the middle of the slide? It says neuron. That's a picture of what, it's of course a comic of a neuron, right? And on the left you've got the cell body, and you've got dendrites going out, those little lines, and then the area between, under the word neuron is the axon, and that part of the neuron is where electricity is conducted. It goes down that axon, and when it gets to the end of it, where those two, it's a synapse, it's where two neurons come close together. When the electricity goes down that axon and it gets to the synapse, it makes neurotransmitters be released into the synapse and picked up by the other side of the synapse. So just to kind of let you know how that works, and we're going to be talking about that a bit. So a TMS works because neurons are electrochemical cells. They are chemical and these neurotransmitters, and they're electric because there's actually an action potential of electricity that goes down the synapse, or the axon too. And so neuronal activity can be induced chemically by the use of drugs or other things, or they can be reduced electrically by interventions like transcranial magnetic stimulation. Unlike drug actions whose effects are anatomically diffuse, they go all through the body, the effects of TMS can be targeted, focused. So under normal conditions of use, TMS has very much fewer adverse events than drugs do. TMS is a powerful electromagnet. That's this on the far left. You can see that purple thing. That's an icon that looks like a the electromagnet that makes TMS. It's turned on, often on in rapid fashion, producing a pattern of pulsed magnetic fields. So if you held that one over a piece of copper wire and you pulsed it, you would, without touching the wire, you would cause electrical current to go down that wire. Okay? What we do with TMS is we hold it over axons inside the brain, and when we pulse it, it makes an electric current. It doesn't take electricity from that one to the axon, but when it gets to the axon, it triggers an electric current that goes down that axon and then triggers the release of neurotransmitters at the synapse. When the pulsed magnetic fields from TMS coil are applied to the left dorsolateral prefrontal cortex, that part of the brain that was blue in the previous slide right under my hand here, there are a series of events that are thought to underlie the therapeutic effects of TMS in the treatment of major depression. First, right under the TMS coil, there is the axons shoot off and release neurotransmitters. So locally, right under there's a release of neurotransmitters. And that's cool, but what is really cool, I think, you can see what I think is, neuronal depolarization of the cortical pyramidal neurons. That's a different kind of neuron that's all through the brain too, these pyramidal neurons. When those are activated, they go all the way down into the brainstem. You see that blue line there? That depicts what else is happening. So there's a release of neurotransmitters right under the one, but it also triggers excitation of that pyramidal neuron that goes down to the brainstem and triggers stimulation of these nuclei that release monoamine oxidation, monoamines, excuse me. And that is probably what causes more than a superficial and brief antidepressant effect. It's probably stimulating those nuclei in the brainstem that actually makes depression be treated. Once we stimulate those and get them working again and getting these neurotransmitters out to the different parts of the brain that we showed you before, it seems to be a self-perpetuating cycle. It's sort of like priming the pump. Once you get it going, it lasts for a very long amount of time. I mean, some people, it will last for years. Some people, it's shorter than that. And some people, it doesn't even work for, but for most people, we do see a response. Okay. So the net action of TMS is, though it's targeted right here, it's part of the brain we can get at. That part of the brain has connections to other parts of the brain that we're actually stimulating. So it's really, it's incredibly elegant to think that you could just hit one spot in the brain here and that could be actually affecting the middle of your brain without actually entering your brain, doing neurosurgery and implanting something there to make it happen, which it's also done to treat depression sometimes, but you might imagine that would be much more invasive than stimulating something on the outside of your head. So this slide shows all these scientific principles in action. We'll just take a few minutes to think about this. This is a group of 12 patients with major depression who've received a course of TMS through their left frontal prefrontal cortex. These pictures represent images from a SPECT scan. It's a kind of imaging tool of the aggregate results of all these 12 patients. So this is an aggregate slide, looking at the areas of the brain that showed changes in cerebral blood flow that correlated with improvement of the symptom ratings as measured by a standard depression scale. The left side of the brain is on the left side of each of these images, just to orient you here. The right side of the brain is on the right side of the slide as noted. The top row of these images shows transverse sections moving from lower in the brain to higher in the brain. So again, a horizontal cut through the brain going from lower to going up. The bottom row images show what we call a coronal section, so that's an up and down slice, going from left to right, or going from back to front of the head. That's shown as you move from left to right. So it's back to front, left to right, bottom side. You can see that the approximate position of the TMS coil is on the left side of the head in the bottom left image. The area just underneath the coil is the left dorsolateral prefrontal cortex, which we've been talking about stimulating. And you can see that that's showing increased metabolic activity as a direct result of magnetic stimulation. You see how it's red underneath there? In other panels, you can also see an increase in metabolism that extends from that area to other parts of the brain. So it reaches deeper brain regions that are important in food regulation that I mentioned earlier. For example, in the middle panel on the bottom coronal section, the middle one there in the bottom, areas of the cingulate cortex show increased activation. And you may not remember, but the cingulate cortex was the second part of the brain as we looked at that one slide. So it's another part of the brain that's involved with depression. So if it shows that not only when we stimulate that left dorsolateral prefrontal cortex we get activation, but because there are these pyramidal cells that will take information into the brain, we're also getting activation of, in this case, the cingulate cortex. So it's really quite an elegant way of entering the brain, I think. I borrowed this slide from a friend of mine. His name is Jeff Levine. Nobody knows him, but he's a neuroscientist in New Mexico at a place called the Mind Institute, where they do just amazing research on the brain. And note the second head from the left. That shows theta activity. This is a quantitative slide. And depressed people have abnormally high frontal theta activity by age. You can see that here. This is before TMS on the top and after TMS on the bottom. And you can see that he's got a lot of abnormal theta activity, the second head in there. And it shows that when you treat this brain with TMS, that the theta activity normalizes. So it's just another example of, that we can actually show that there are real changes in brain activity by using TMS. The high frontal theta activity normalizes, which we know is a marker of depression. So not only do people tell us that they're less depressed, but their brains, when we look at them with EEGs or SPECT scans, show that there's changes. So I've showed you a little bit about how it works and what it really does to the brain, but does it actually really affect mood? Does it really, if you come in and get it, is it gonna make your mood better? What are the chances of that? So this slide is from a large study of patients with treatment-resistant depression treated with TMS. The people who entered this study would have had a 6.9% remission rate based on the start of the study. All these people had failed at least 4 drugs. The remission rate based on self-report in TMS-treated patients in this study was 28%. So you can see that 28% is the remission rate on the right bar graph. 56% having a greater than 50% improvement rate. So to me, this is a phenomenal improvement compared to 5% or less. And that's the difference that we're talking here. So I'm going to just show you some real-world data that we did early in my treatment of people with TMS, and the reason that I got really, really excited about treating treatment-resistant depression after trying to treat it with drugs for most of my life. This was really exciting to me. So this was just the first 73 people that we did with TMS. They were treated between 2015 and 2018. All were severely depressed based on their scores on these rating scales, PHQ-9 and MADRS depression rating scales. All had failed at least 5 antidepressants. Some had failed as many as 20 antidepressants. The average person had failed 8 antidepressants. 40 of the 73, that's 55% improved, more than 50% based on their depression scale scores. 25 of the 73, so 34% returned to normal, their depression scale was normalized based on the depression scale scores. 7 of the 40 responders relapsed within 3 years. And I mentioned that because, remember before I said that normally when people are treated for depression with antidepressant, there's about a 50% response rate per year. This is a 17%, I'm sorry, I said that, a 50% relapse rate per year. With this study, we had a 17% relapse rate over 3 years. So less than 10% per year, which frankly to me was the most exciting part of the study that we did on ourselves here. Since then, we've done approximately 20,000 TMS treatments. We've treated hundreds of patients between here and Minneapolis. We average treating about 25 people a day. Our response rate as we've gotten, I think, better at doing it and using some tricks that we've learned along the way is more like, we think we're having about a 78% excellent response rate, people who feel like this has meaningfully changed their lives. So it's pretty good compared to 5%. And at the same time, we're not seeing side effects. And this is drug therapy versus TMS. So what do we have? What kind of side effects do we have? We see topical head discomfort, just from the stimulation at stimulation site, which almost always resolves almost immediately after treatment. And most people don't find it toxic. We've had a rare person who's felt a little bit of fatigue after treatment. We had one episode of hypomania, which responded to a mood stabilizer. So there are potential problems, but they're very rare. And if you watch for them, you can avoid them. So again, topical head discomfort, fatigue, and one episode of hypomania. So what would a person expect if they're going to have transcranial magnetic stimulation? Well, they're awake. There's no sedation, no anesthesia. Generally, there's no sedation even as a result of the TMS. There are no negative effects on thinking or memory. Right after TMS, you can drive home, you can go back to work, you can function normally. In fact, there's probably statistically some improvement in cognition after TMS, which is probably related to the fact that depression causes cognitive impairment because of lack of energy and focus and that sort of thing. Again, some people have mild to moderate pain at the site of the treatment, and you have none of the side effects that you see with typical antidepressants. No weight gain, no sexual dysfunction, no sedation, no nausea, no dry mouth, no adverse effects on concentration, and no drug-drug interactions. Uncommon serious effects, seizures. They've occurred in 1 out of 30,000 treatments in early studies. We have now done, we're in tens of thousands of treatments, and we've never seen a seizure. We believe that the early seizure that was seen was related to a certain kind of machine that was more aggressive than subsequent TMS machines. And they were also always related to people who had been drinking or were taking a drug called Wellbutrin, which lowers the seizure threshold. So we obviously tell people they shouldn't be drinking in the time frame that they're doing TMS, and we usually back off with Wellbutrin. Mania is a rare symptom, and it needs to be taken seriously, so we screen very carefully for people with mood instability, bipolar disorder. We do treat people with bipolar disorder with TMS, but we treat the mood instability first. We have them on a mood stabilizer, and with that, we've never seen a problem with mood instability. You could potentially have hearing loss because there's a tapping sound. Sounds a little bit like a woodpecker. We had one patient who we were talking about this morning who said the woodpecker was so good to her that she wanted some symbols of woodpeckers to have around her house so she could remember the experience because she had such a great response. So what is the process? What, if you are depressed, what do we do to get people ready for this? Well, first of all, we do an initial evaluation, and that is a very, very thorough psychiatric evaluation, looking at all the medicines you've tried, how deep is your depression, do you have mania, do you have psychotic symptoms, what other medical problems might you have, just to be sure we're addressing all these. We also, in our clinic, do an extremely broad organic workup. So we do a lab panel that takes 12 test tubes of blood. We look at everything from metabolic factors to mineral levels to every hormone level you have to other things. Vitamin levels, yeah. And what we found, I began doing this early on, and what we found was that everybody has several that are off. And if we treat those, they're often very simple to treat. Like a low vitamin D level is pretty easy to treat. Just take vitamin D or get more sunlight. A lot of people who are treatment resistant have low levels of hypothyroidism, levels that might not be diagnosed by a typical primary care provider, but as a psychiatrist, I'm looking at it and saying, I want you to have an optimal thyroid level, not just in the normal range. I don't want you to be in the low normal range. I want you to be in the optimal range. So we optimize all of these variables, and I believe that is what prevents us from having this high relapse rate, because when we treat people's underlying subtle medical problems, they're much likely to not relapse. That's the only thing that we do different than other TMS clinics do. And our relapse rate is, as I mentioned, is pretty low. And most TMS clinics that don't do this have about a 50% relapse rate per year. So it's really, really big difference. It's the only thing that we do different. And I think the magic of our model, actually, you might see that I'm pretty excited about it, because it really does make a difference in how people do over the long haul. Treatment occurs 5 days a week, 6 weeks. It says less than an hour. Actually, now with our current protocols, it's probably, most people are the office in less than 20 minutes. You drive in, drive out. After you do the first 6 weeks, we usually do a maintenance protocol for about 6 weeks, once a week. And then their lives, drive themselves to and from treatment, and it's, so people who live nearby, it's very simple. You just drive in, do the treatment, go back, and get on through life. It's harder if you live more than an hour away or whatever, which we actually get a lot of patients who do live a long ways away. So that's a problem. We're trying to develop protocols where we can compress the treatment and do more in a shorter amount of time. And there is some of you may have heard there was a study out of Stanford called the SAME study that did 50 treatments in 5 days and had excellent response rates. It's pretty intense to do that, but people do get a very rapid response to it. So, and we've done it on a few people in our area. People who live in Faith or Gillette or someplace like that. It's just not feasible to drive back and forth every day for 6 weeks or even 3 months. This is what our machine looks like. It's called a cloud TMS machine. The wand is on the left, and I'll show you the next slide. We take that wand and put it, here it's being placed over the dorsolateral prefrontal cortex. We put it there, and then we lock it in place. A person could move their head and get away from it, so it's not like they're tied to their head. It's but they're just asked to sit still, and it's not toxic, so people have no trouble with sitting there. And if they know if it's not touching them, they're not going to get the benefit, so they need to make sure that it continues to touch. So who should consider TMS? Depression is tough. If you've ever had it, you know just how miserable it is. And I just show some of these next slides because I think if you haven't had it, they give you some idea of what people are thinking about. Your head is surrounded by a thick, black, unrelenting fog, exhausting like you're living in a cage. You need to hug someone, but at the same time, you don't want any human to hug you. You have a lump in your throat as if you're about to cry at any moment all day. And all you want to do is go home and just curl up and fall asleep forever. It's a tough problem, tough medical problem. It's a medical problem that's treatable. Lots of people have it. This kind of represents that 850,000 deaths each year responsible for. Any given year, 20% of adolescents will experience a mental health problem, most commonly depression or anxiety. That's increasing. The talk we did last time, a couple of weeks ago, was all about the mental health crisis and how rapidly the mental health crisis is increasing in the millennial group. Leading cause of disability in the United States. In the 90s, I did a lot of forensic evaluations, assessing for workers' comp claims. And what I found was that almost everybody who had an injury that was disabled was also depressed. People who had an injury weren't depressed, generally were not disabled. It was interesting to me. I mean, that's a little bit too broad a statement, but depression on top of a disability is very, very difficult. Suicide reached a record high in 2017, or maybe even got higher since then. As you probably are aware, the reservation counties are often have the highest suicide rates in the world, not just the country. So what are the roadblocks? Well, insurance does cover TMS. Almost every insurance company does. Covered by Medicare in every state. Typically requires failure of 3 to 6 antidepressants, at least 2 classes, plus a failure of psychotherapy. So you can't get insurance cover unless you've had some failures. Having said that, I just want to mention that it may well be that TMS is the best treatment for people who haven't failed any antidepressant also, because it has a more permanent effect. So TMS is a focal, non-invasive form of brain stimulation using electromagnetic conduction. FDA approved for many years now, 14 years. Safe and effective, it's well tolerated, no systemic side effects, and it should be considered for people who failed other forms of depression or antidepressants. Just one other thing just to talk about is that we're using TMS, and I think we're going to see it being used more and more over the next few years to treat a variety of other problems. We know it helps anxiety disorders for a lot of people. We use it often. We often treat both depression and anxiety simultaneously using a different protocol in a different part of the brain. We know we can treat OCD with an obsessive compulsive disorder, and at least drop the symptom load significantly. I've treated Tourette syndrome with it and seen a significant reduction in Tourette symptoms. I think that we will know how to treat hallucinations with it before too long. There's studies being done on this. So, we're just in the early phases of finding out how to stimulate the brain and how to use that tool as well as possible. Exciting stuff. Yep.
So effective has been the side effects. I don't understand why it's not used as first line treatment.
Yeah, so Bob is asking why is it not used as first line treatment? And I think it is basically the cost of it. It's
Isn't the cost of medicine over a period of years?
And suffering.
exactly.
But maybe that'll change.
So for me, and I was impressed, and I've got a machine in my office, of course. I wouldn't bother with medication at all. I mean, I just do TMS. We try to treat anybody who needs it, whether they have insurance coverage or not. But it just covering our overhead probably is about $100 per session, so that's about $3,000. So it's a meaningful amount of money. But as you say, the morbidity of depression is significant.
In the picture, it showed a gentleman with a shaved head. Is there any problem with conductivity through like hair, maybe an afro or something?
Yeah, so what we do, we don't actually put it on people's heads. We use like a skull cap that's tight. So we take your hair and compress it, and then we haven't had a problem with that. And what we do to figure out the strength to use is so there's a part of the brain that's right between the top and your basically it's called a motor strip. So we put the cap on people's heads, and then we go through their hair and their skull or whatever, and find out the amount of energy it takes to stimulate the motor strip and cause your finger to move, a little movement like that. And once we know how much energy it takes to get that deeply into the brain through the head, through the hair, whatever, then we know how much it takes to stimulate the dorsolateral prefrontal cortex also.
How long do you hear the woodpecker, or does it vary in treatments?
Just during the treatment.
But what's the length of time of the average having to listen to that?
3 minutes.
3 minutes.
Yeah.
Oh, okay.
No, our standard treatment is 3 minutes. We often do a second treatment that's about 6 or 7 minutes. That's another woodpecker, but a slightly different place.
Is it as loud as a
Nowhere near as loud as an MRI. How loud is it? It's about like about like that. Yeah. Yep.
Well, you know what I have, but I wondered, I have like the autoimmune thyroid plus supposedly bipolar, but I experience depression like every single day. So I wondered if I could respond to something like this. And then also, like after you've done 6 weeks of treatment, do you go a year without doing it? Do you do it every couple of years? Or?
Yeah, so, we would want to be sure your thyroid is treated.
Right.
Like I said, we look at thyroids on everybody, virtually, unless they refuse to have it done, which I think is a huge mistake, but if it's low and you don't treat it, we're not going to have as good a response. With bipolar disorder, there is a risk of triggering mania, so we're careful with that. And I guess, without knowing your whole story, it's hard to say, but we do treat bipolar disorder. If we have a good response after the normal 6 weeks plus another 6 weeks of maintenance, we would hope to have 6 months of benefit at least. As I mentioned, the relapse rate is a little bit less than 10% per year, so we generally get much longer than 6 months. But we do treat again before 6 months if people relapse, if they've had a good response. If people haven't had a good response, then we're looking at something else, or it might be a little bit different placement, because if you can think of that brain that we're looking at, and looking at the middle of the brain, that's really, we're trying to get into the middle of the brain, using the entree through the dorsolateral prefrontal cortex, that's close to the skull. But there's other ways to get in there too. So sometimes we treat on the right side, sometimes we treat right under right above the eye, because you can get under there from that location. And so there are other ways that get added. I believe what's happening is people just have different kinds of connectivity to those parts of the brain that affect depression, and we're looking for an entree into that area. And the most common entree is right here, but there are other places that we also look for. So we might, if we had a short response, we might try something else.
Okay, thank you.
What part do concussions play in that, whether they're old or new or severe or frequent?
Yeah, so that brings up the question of if you've got a brain problem of some other sort, right? Is it dangerous? Does it help? So we worry a little bit about fresh concussions, particularly because of the risk of seizures. Probably lowers the seizure threshold. So I would be cautious in that group. I would maybe use a different way of treating. So I didn't really explain this, but normally we stimulate this part of the brain. It's rapid pulses. There's another way of treating depression that we treat the right side, but we inhibit it. And that works about as well. So for instance, we have a person that we're going to start next week who has a history of several concussions, and he had a seizure a long time ago, so there's some concerns about seizures, and he's got some medical problems, and he was referred by the VA, and they said, just treat him, and I said, well, I can do that safely by doing the inhibitory protocol on the right. It never causes seizures. It actually decreases the risk of seizures. Now, does it help concussions is an interesting question. I'm not aware of it helping with, say, a post-concussive syndrome, but whenever we treat depression, the concussion is a trigger for depressive symptoms, which it sometimes is. We can have a response even with people who have concussions, so that's not a problem.
If you did it on a normal brain without depression, would they be even happier?
Yeah, so could we make a normal person happier? Doesn't appear that that works that way. But it's an interesting question. I mean, because, and the other treatment that we do for treatment is depression, which is ketamine. We do have people who are looking to be happier than normal. And that's not our goal. But, so no, and I'm pretty sure it doesn't, because we've all tried it. I've tried it on myself. I'm confident enough that it's not going to do any harm that I would do it on myself. And I know a guy who does lots of, he teaches how to do it, and he does it on himself all the time. And he's happy, but so it doesn't appear to do anything that makes you euphoric, so to speak. Interesting. Maybe if we knew the right place to stimulate.
That's where you vote to legalize marijuana.
I'm not thinking about that. Yeah.
I had a couple questions. One, when you got a diagram up there of neuron transmitters carrying the electrical signal to the next neuron and so forth around the brain. Does the TMS create an actual more movement of electrons, in other words, an electrical current, or does it simply change the polarity of chemicals in the brain so that the electrical impulses can move more freely?
Okay, so when people are depressed, they actually have atrophy of parts of their brain. They have atrophy of this area under my hand, or the dorsolateral prefrontal cortex. And we think that what we're doing is, they're not getting probably much electric current down there because it's not receptive to that, because it's atrophy. And we are pushing a current through there, causing an action potential that makes that neuron fire. And by doing that, stimulating these neurotransmitters and causing, kind of priming the pump, so to speak, and making that get going. And we think that we're stimulating a circuit. I mentioned these pyramidal neurons that go into the middle of the brain. There's probably a circuit that goes in the middle and then comes back out. And if you can get that going, you continue to stimulate the dorsolateral prefrontal cortex even when you're not getting with the TMS power.
Well, now, the second, that the long-term improvement, is it directly related to improvement of the vascular system so that these cells have a better blood circulation?
No, it probably is. It's getting that. My theory about it is that it's. Think of the synapse between neurons as it's like some water that's got different stuff in it. So we're getting neurotransmitters into that fluid-filled space. And by doing that, I think that's what's really causing the whole system to get going again, by getting that moving. And I believe that that's why when we work on brain health by making your thyroid normal and getting your vitamin D level normal and treating metabolic syndrome and all that stuff, why that helps is because it's really treating the milieu of that synapse. Being sure you have enough thyroid hormone in there, and estrogen, and vitamin D, and copper, and zinc, and other stuff. That is when people have optimal amounts. It seems logical to me, and I think that's what we're seeing phenomenologically, that you just have better conduction through the whole process. So that's this is my theory about it. There's not a way of showing that, or we haven't figured out a way to show that yet. But we do know that it does get the whole system going again, and exactly why it does that and why it continues to keep going for a pretty long period of time is slightly, somewhat unclear, I'd say.
I have a question about that. If someone did have metabolic issues that you had to straighten out, how long might that delay their first treatment?
So we treat right away. Because,
you do?
yeah, we don't wait to fix it. We get fixing it as quickly as we can, but it appears that TMS will treat depression even if you don't do that, even if you don't address all those things. What you miss is you relapse faster. You go to TMS clinics around the country, they have around the same response rate that we have.
Okay.
But what I don't see is that they prevent relapse.
So don't they know that you're doing better than them in that, and they would want to copy some of these protocols?
Well, we haven't been super public about it, but it's a kind of a hard thing to publish because it's a hard thing to study because most studies look at an individual variable, and we're not doing it. We're changing 5, 10 things, so it's really tough to. And there aren't. I mean, you could say the same thing about treating a tumor. Most of them look at a single chemotherapeutic agent or a few and see how they work. But there are other variables that are going on too, right? And so it might be that if you did all these things with a tumor treatment, you'd see a better response too. I mean, it sort of seems logical in a sense that if you got a person otherwise into a high physiologic range, that they would be healthier, and that you would be better able to fight off the illness in their body.
Yeah.
So I don't, but it's hard. It's hard. My son was a cancer researcher, and he was bringing this up, and they're just not. They don't have a way to do that very well that meets. You can get funded for studies and stuff like that.
But you've seen results, obviously.
Yeah, and that's partly really why I opened the clinic in Minneapolis was my mission in my last act of life is to I think we need to get this out, and get it out in some places and get people seeing it and talking about it, and because I mean I'm not bullshitting you here. This is really treats depression that other people are treating extremely well, and it's really a big deal for a lot of people. I mean, 30% of depressed people, when you consider the number of people with depression, any given year, it's something like 15-20% of the population. So it's really a big number.
And the economic.
I mean, just I mean, if you've been depressed or if you work in with other people and somebody who's depressed, they don't want to work, right? I mean, it's hard to work when you're depressed. They don't want to come in. They don't just even if they're there, they're not as functional as a person who's not depressed.
You talked about the atrophy in the brain with depression. I mean, outside of meds and TMS, what can a person do anything besides like eat healthy to like help with that atrophy?
Yeah, for sure. And I'm going to do a talk on that about brain health soon. I think I'm not quite sure when, but it's a topic that. Yeah, I mean, I think it's a big, because it affects every kind of brain illness, and in fact, every kind of body illness too, because they're all connected, right? I mean, the brain is connected. So, I mean, I think thinking about all of those variables, and then thinking about one thing that we started doing early on with TMS, because we see people every day, so we got a lot of contact with them. I remember I was cutting the grass after I bought the TMS machine, and I thought, you see these people every day. What? I mean, I just never have an opportunity to have that much therapeutic contact with people. And so what could we be doing? So I began to, dream about options. And so what we do now is while people are getting TMS, we're working with them on getting into some kind of an exercise program, some kind of an eating, improve their eating habits, some kind of meditative experience that they can do regularly, some kind of socialization experience, because when people are depressed, they stop socializing, and work on sleep also. We think, I believe that if we did that with everybody, my clinic would empty out, we would have no business. Which would be great, right? But I'm not too worried about that yet. But those are hard, lifestyle changes are hard to make too. And it's really unusually, we have an unusual opportunity during TMS to, do a coaching job with people. We can say, I remember one guy, I said, so what do you eat? And he said, well, takeout. That's it, I said, well, why? Well, I can't get, I can't, I don't get out of my bedroom, much less think about making a meal. And so he said, well, so let's talk about takeout. Where to get your takeout? So we began to talk about places to get healthier takeout. And then we talked a little bit about diet as we went along, and he got better. His depression improved, and he began to say, yeah, maybe I could do something more. So anyway, long story short, by the time he was done with TMS, he was eating a completely vegetarian diet.
Wow.
Within 6 months, he had lost 60 pounds, and he said he couldn't exercise because his knees hurt, and he was so you don't have to run, you don't have to jump, but what could you do? He got a recumbent bike, and he could do that, and he was riding his recumbent bike every day, But it was the combination of having lots of contact, lots of coaching, talking with them, and his mood getting better, kind of goes together. Then we could, get a synergistic effect. So I'm with you. And I think that is what keeps people from relapsing if we do that well. Sometimes you don't do it as well, for a variety of reasons. But if we can do that well, then I think we've got a real chance of changing people's lives.